Morning, sir.
Good morning, everyone.
And actually, we are waiting for our principal to join. Dr. Sharath Ashokan will join soon. Okay.
We welcome our principal, Dr. Sharath Ashokan.
Yeah. Thank you, ma'am. Thank you, ma'am. I'm here. I'm inside.
Good morning, all. I welcome you all for our CDE program, Out of the Box 2022. It aims at imparting knowledge to its participants and will make you rethink the way you do endodontics. Today, we have two seasoned clinicians and academicians, Dr. Hannah and Dr. Nandini Suresh, who will be imparting their knowledge to us. Dr. Nandini will be talking on 3D printing. This topic was chosen as, Dr. Hannah will be talking on 3D printing. This topic was chosen as the development of new materials and technology will be the future trend of 3D printing in dentistry. And there is no denying that 3D printing will have a bright future. Dr. Nandini will be speaking on root resorption. Root resorption is of main concern to the dentists. Dental clinicians can be faced with difficult diagnostic and treatment decisions with respect to tooth resorption. Hence, this topic was chosen. I request our beloved principal, Dr. Sharath Ashokan, to say a few words.
Yeah. Thank you, ma'am. Very good morning to one and all present here. At the outset, I would like to congratulate the Department of Conservative Dentistry and Endodontics for organizing such an event, choosing some good topics and some good speakers as well. About the speakers, I think I have to keep again informal because I think I know both of them, at least from my PG days, Dr. Nandini and Dr. Hannah. Thank you so much, Nandini and Hannah, for accepting our invitation and being ready to share your experience on this particular topic. I'm sure all the delegates and participants will definitely benefit out of this program. All the very best and congratulations to the department. Yeah. Thank you, ma'am.
Now I request Dr. Deepa to introduce our speaker, Dr. Hannah Rosen.
Good morning, all. It's a great privilege to introduce Dr. Hannah Rosen for our today's presentation. Dr. Hannah Rosen has completed her MDS for PhD in 2019 in endodontic microbiology. She was a professor in Sri Ramachandra Dental College with an experience of 15 years. She has 20 research publications, reviewer in various scientific journals, role part in editing endodontic microbiology chapter in Grossman Endodontic textbook in 2021. She has presented various guest lectures and research papers in national and international conference. She has received 3 best papers in national conference. Currently, she is the co-director of Center for Technology Assisted Reconstructive Surgery. Welcome you, ma'am, for the presentation.
Yes, Dr. Hannah can.
I think we should also add that they are friends of Dr. Karthik.
Should I start the presentation, Karthik?
Yeah, I think Hannah, you can start. I think they're not. I think you can start.
I can start.
I can hear you.
Yes.
Yes. Good morning, all. Today's topic is 3D printing demystified. Okay, first of all, I'd like to thank the entire team of KSR Institute of Dental Science. I'd like to thank Dr. Sharad, whom we looked upon, and we really thank you. And we are so happy to see you as a principal. And we'd like to thank Organizing Secretary, Dr. Sabina Matthew ma'am, for giving us the opportunity to speak on these topics, which we also were not very familiar. We learned and we would like to show it to us. And we have got some experience over this. And we'd like to thank the entire—
Excuse me, Hannah. Hannah, you're not very audible.
1 minute, ma'am, 1 minute.
Can the other participants hear? I think it is audible for us actually.
Oh, okay.
Can the other participants from somewhere else?
Yes, sir. I can hear you.
Yeah. Okay.
Okay. So maybe you can
Yeah.
continue.
Yeah. Yes, ma'am. I think it's some technical thing. We can hear you also.
Okay.
I think Hannah, you can go ahead. Just keep it.
Yeah.
Hannah, unga voice la pesama konja satama pesinga.
Clear, Arka?
Yeah. It's clear, Hannah.
Okay. Sir, I really thank you, sir. And we're so proud that you've become the principal, and we like to thank our organization.
Hannah, you call me Sharath. Don't call me sir. You call me Sharath, like as usual. Yeah. Thank you.
And organizing secretary, Dr. Sabina ma'am, for giving us this opportunity. And we'd like to thank the entire organizing team, especially headed by Dr. Karthi, our dear friend. Is still the same like a PG. So we're really happy. And let's go on to the topic. And this topic that you have given to me is something which is so innovative, so experimental, clinical, and educational. Still, we are not up to the mark in our dentistry as yet, because many people around the world have gone to 4D, and still we are in 3D. So for us as PGs, as students, as doctors, to know what's 3D printing, what I have learned, I like to share it with you all today. Okay, so first for basics, as first year PGs or any interns who are there, you have to know the difference. What is this 1D and 2D and 3D is. Before we go into the main topic is, 1D is just describing only like one measurement. Okay, if it is 2D, you see an axis like any XY, whether it's a triangle, box, or a circle. But when you see 3D like this, it is your height, weight, and height, depth, and width. Okay, so what you see is, whenever we get to see a 2D like this, it appears to be a 3D like this. So wouldn't you like to see a tooth or a teeth, the whole set, in a 3D view? That is what today I'm going to speak about. And here we see 2D versus 3D in dentistry. Just look at the first X-ray over here. Okay, this is a 2D image. This obturation looks fine to me. Okay, I might put him on an antibiotics if he has a pain and wait and watch. But when you take a CBCT or when you take a CT, which is a 3D, just look at this. We have a missed distobuccal canal with the periapical lesion. Did we see it here? No, but we did see it here. Same thing, you can see it in this X-ray, the last 6, the molar tooth. Did you see anything in the X-ray? Maybe I could see a little lesion over here, slight rarefaction. But when we take a CBCT, you will see clearly there is an external resorption. This is what is 2D versus 3D. So every treatment, if it's going to be based on this, it will be better, right? So let's move on to the first person. This is a little physics, little engineering as well as dentistry together. Now coming to 3D, the first person who is Charles Hull, who brought this 3D printer. Of course, he didn't bring to dentistry. Then this 3D printing is always also called as, every time we don't say the word 3D printing, we use the word additive manufacturing, rapid prototyping, layered manufacturing, and solid free from fabrication. Any things would be repeated in your articles. So don't get confused, it is 3D printing only. If you call it as an additive manufacturing, it is 3D printing. Okay, so what is this 3D printing? It's called as the additive manufacturing. So when you use the word AM, you always remember it's 3D printing. Any digital file that comes into a live in your hand, this is your 3D printing. That's all is the whole story. We'll just go about how it goes, okay? So what I said was additive. This is 3D printing. Layer by layer, some material is being put to get a model in your hand or whatever you want, a guide, an implant guide, a new material, a denture, anything mostly goes within additive process. What is the subtractive process is? It's like a block is given and you cut it, right? Like how you see it in your zirconium, right? They give you a block and they cut various crowns. Or simple for you all to understand, if an intern is there, a wax block you take and you carve a tooth. So that is subtractive, okay? Then formative is you have a mold and you put in some material inside and you get multiple models from one mold, like making a lot of toys from one mold. Or for your ortho, you make a lot of things from a silicone mold, models. This is formative. So just a basic idea when you see your articles, what is additive, what is subtractive, and what is formative. So coming to the next is where all is used. You can see it yourself. It's used in healthcare, food, everything 3D printing. Why we dentists should be less, why we dentists should be not knowing about this is what today's topic is all about, okay? Today we are talking about 3D, but here we have gone to the level of fourth dimension. What is this fourth dimension is, whatever we fabricate, it goes along with time. That is, you have a temperature, maybe a slight change in the material, because what they are using now and trials are going on is shape memory materials in 4D. So this is what is 4D. So we are stuck up still in 3D. Okay. So now the future of 3D. So today the whole presentation is based on three things. Why? Why do we use 3D? What and where all we use? Okay. For all the postgraduates, I've put all the articles together. You can just see which interests you. And if you'd like to have in your articles, you can ask, I will send it to you all. So first is, why is 3D printing technology moving forward? Why? Okay, in which field does it go? In every field you have 3D technology, whether ortho, endo, implants, prosto, perio, and surgery, they're using right royally 3D printing. So coming to this, first, why are we using this? Because you have an improved diagnostic tool, virtual planning, and improved choice of material. The second question that I like to put is, what are the requirements? Today, I want to do an implant guide. For an endo PG, we want to do a stent with a sleeve, right? We want to do an endodontic guide. For example, we have a patient with a calcified canal. Okay, now what do I do? Is your doubt. Now let me just go with the sequence of this. So what are the requirements? Okay, the first thing is, what scan do I take? 2D is not used, X-ray is not used. So what scan do I take? So either CT, CBCT, or micro CT if you have, but mostly it is CBCT. Why? You can ask me, why not an X-ray? The second question is, why not an X-ray? Because you have geometric distortion. You can view only a mesiodistal and apical coronal in a 2D plane, but not in a, you can't see a buccolingual. If you have a buccal caries, it's very difficult to find in a X-ray. Third one is superimposition. So this is what is why we are not using an X-ray. Okay. Now coming to CT and CBCT, you can ask why it is called CBCT and why CT. See, this is a CT image. Okay. So every time we have one rotation, we have one axial plane formed. Likewise, multiple rotation, you get multiple planes. This is called CT. But here CBCT, what happens is, with one rotation, you get all the slices in a volume. Okay, that's why it's called as digital volume tomography. Okay, so most of our dental for endodontic applications, your CBCT is enough. So you got it now. So we will go for the slice thickness. Okay, mostly our slice thickness, which is enough for doing a 3D work, will be CT scan is 0.6 millimeter slice thickness. CBCT is 0.3 to 0.5 millimeter slice thickness. This is what they give it to us. Okay. Now, two things that a PG has to know is, whenever we read an article on 3D printing, there are two things which always confuses us. Okay. What is this pixel and voxel? In a 2D, the basic image picture element, that's why it's called PIXEL. So pixel, picture element, the smallest picture element is given in 2D. Whereas voxel, the volume, because I told you the CBCT takes in volume. So volume element, the smallest individual volume element is 3D scan. Okay, so you got the difference. What is pixel and voxel? So whenever you use 3D and scan, you use the word voxel, not a pixel. Okay. So the first step, you send the patient to a CT, okay, whatever CBCT you take. Now for a PG, most of us are digital, right? Now when a picture comes like this, a first year PG student gets a little annoyed. How do we interpret this? Okay, what I learned, I like to share it with you all. Suppose this is a maxillary arch, okay? Now, how do I see which tooth is which? Every slice looks, the sagittal slice looks same. So now, just for everybody to know, just 1 minute, please. Sorry. So here what we do is now see, now I want to see a lateral incisor. Okay, I want to see the thing as lateral. What is the number given here? It's 40. Okay, this 40 is here. Can you see the number 40 here? So you want to see the lateral incisor distal to it. You can see 40, 41, 42. So a PG can itself interpret depending upon the slice. Suppose I like to see another tooth over here in the canine. So I know it's somewhere between 25 to 30. So you go look out where is 25. So somewhere between 25 to 30, you can see your canine. This is how you interpret a scan which is given to you. But now most of the time it's digital. So it is very, very easy. You can view it. And one more thing is anything that you want to measure, everything is given over here in a scan that comes to you. Okay, the file that they send it to you, you get everything. So now you've got this file, you've sent a per patient, you've got this. Then what do? Next is what comes to you is in a DICOM file. What is DICOM file? What I showed you now, digital imaging and communication in medicine. Okay, this one. Now you want to send it to print. You want to play with it. You want to cut. You want to measure the tooth length. You want to know where you do your root resection. Where is a surgical osteotomy you want to do. Everything cannot be done in a DICOM file. It has to be changed into something called STL file. That is called as standard tessellation language. It's nothing but the image is made into triangles and polygons. Okay, like this. This is what is called as standard. So with this only you can all transfer your things to your printer. You can cut, you can do your abscess, you can check out your abscess. Everything is in your STL file, okay? So once DICOM to STL conversion is done, there are softwares, I'll just show you also, okay? And every PG has to know what is this reference plane in a CBCT. First is your axial plane. This is what is an axial plane, okay? This is your sagittal plane. This view is your sagittal plane in between, okay? What is coronal plane is the front view, the front and the back view, okay? So now for making it more simple, I will tell you, coronal is what you view in the front here like this. Sagittal is sagittal plane. Transverse is this way, axial plane. So the axial plane is otherwise called as transverse plane in your cross section. So you got this, so you will see a CBCT and interpret yourself. Once the CBCT is done, now the next question comes is, how do I send, what do I write and send? Do I want the entire skull? Do you want the entire thing? Is something called as field of view, okay? There are three types of field of view: large field of view, medium field of view, and small. What is large field of view? The first one is whenever people want for maxillofacial trauma, orthodontic, TMJ, they take a big, large view. For second one is medium view. For what do you require for any implant planning, pathological, you can write to that particular area. The third one is small FOVs. That is 4 into 4, less than 10 centimeter. This is what is N for endodontic application. So when you are writing for a CBCT, write small FOV because it is less than 10, particularly nearly to 4. So they will view the area that you want, near to 1 or to 2. Okay. So am I audible clearly?
It's like,
is there any break or is it clear?
Hannah, I think it should just come closer to the system. Now it's clear.
Now it's clear? Okay. So the large field of view, medium, and small FOVs. So you got this now. So when you prescribe and when you write to a CBCT, you will put it as small FOV for endodontic applications. So the next one, there are other different CBCT gives you, they give you a prescription to write, right? So here you have a full view, sinus view, double arch view, focused view. So we can give it as focus view, okay? It's depending upon the different things, different, different, like RT scans give different scan centers give different, okay? So once this CBCT is taken and you have sent it to the center, whichever center you've sent it, they will apply threshold. What do you mean by applying threshold is every tooth or a bone has a different threshold. They will apply that particular threshold. Second one, they will select the particular region growing, okay? They will select the particular region growing. And once it grows, they will convert it into a 3D. Suppose I want the mandible, right?
So that will be converted into a 3D. Okay. Now, once it is done, it is given as for a print, either a 3D model, or you just want to digitally plan. You want to see the length, you want to see where your calcification is. All this can be seen in digital planning. Okay. So this is a flow chart that I have given to you. What are the requirements for going into doing something with 3D? You need all these three things. So you can get your models printed. You can see where your nerve is, where your periapical lesion is. Everything can be in your hand before you do any surgical procedure or a calcified canal. Okay. So now the second thing you require, first is I said about CBCT scan. The second thing that I require is intraoral scanners. Most of us do not have this. Don't get worried. Okay, if you have this intraoral scanner, you take a scan and send. Why do you take a scan is because when you fit in your stents with sleeve, it should fit pakka because the cusp should not shake. Okay, but this gives an extra addition to it. Now you might ask question, we don't have an intraoral scanner in our clinic, in our college. So what do we do? So here you take a model, send it to the lab that is near you. You will have, definitely everybody will have a model scanner. They will scan it and give it to you. So when you send for some stent or a guide, endodontic guide, you send the CBCT along with the scanned dental cast. It comes better this. Many centers do without this cast scanner for endodontic. You just need a little trimming of the cusp when you fit in the guide. Okay. So coming to the conclusion of the first part, I have thing is you have a CBCT to be taken. You have an intraoral scan, fine. If you don't have, dental cast scan by model scanner. Okay. So you need all these three things for any 3D printing work. Okay. So now we go to 3D printing. Now, before we go into where it is used, some idea when you read your article, you have something as 3D printing techniques. So basically, we should know what are these techniques. There are lots, okay? I have put what is so much used for our endodontic applications, okay? The 4 things that is there is fused deposition modeling, selective laser sintering, stereolithography, and polyjet printing. Don't worry, I'm not going to explain everything in detail, but you should know because our articles have these 4 names coming together always. So we need to have bioprinting. I'll tell about this bioprinting at the end, okay? So first one is your fused deposition welding. This is the oldest technique. Okay. Here what happens is the material, the resin thermoplastic material comes in a nozzle like this, and you make your toy, you make your models like this. Okay. The material that is used is ABS. So here they use this material and form these models. Okay. This is called fused deposition melting. This was a little older technique because it is thermoplastic. Today, what we mostly use is your laser, light-oriented resin material. Your photopolymers are used here. There's a stereolithography, that is SLG and SLA or SLS, selective laser sintering. These both are the one that is commonly used now, okay? So for whatever work that you're sending to the lab, they use this SLA and SLS. So what is this SLS? They use powder-based material, your photopolymers. It's something like your light-cure material, but they use a powder. SLA uses liquid resin material. That's all. So you have first is FDM and SLA and SLS. And the final one is polyjet resin. This you can color your models. You want to do some study. Your enamel can be colored differently, dentin, and your pulp can be colored red. And it can take up to 25 microns, very small and a very good printer, but quite expensive. Okay. So these are the 4 techniques that is used today for our endodontic applications. Okay. And this is for totally oral surgery. If anybody is there, all your metal printers are printed by DMLS. That is totally a different. If anybody wants to try out your own postcast, post anything, you can try your own things. Okay, creativity doesn't have a limit. Okay? So take home message of the first part. Okay, 1D, 2D, 3D, 4D. All of you know that 4D along with time has been in trial now. So what are the requirements for 3D in dentistry? I have told you CBCT, scanning of your model or as intraoral scanner. The third one is basics on 3D printing. Okay, what are the 4 types, which is FDM, SLS, SLA, and polyjet printing. So this is a take home of the first part. Okay, this is completely little engineering. Now we'll enter into where endodontics take part. Okay. So before that, I don't want to bore you all with 3D printing. So for students, only for students, this, does space use 3D printers? I don't know if you could answer this question or thing, but I will say, does space use 3D printers? Okay. You know, way back in 2014-15, NASA from Earth has given a signal to the 3D printers. They had used FDM and they printed the first print from 3D printer made in space, NASA. How nice to see in 2014, but the signals were given from the Earth, NASA here, but the print was done in space. And today's second question I like to put is, NASA wants to build a lunar base by 2030. Maybe after 2030, maybe I don't know, by 2050, maybe city will be created and everybody will go for a holiday. It's 3D printing with moon dust. That means what is, from moon's top layer called a regolith is being used to build a lunar bases here. Even they have designed such a way, every country is designed now to make their own city here. So they have gone with 3D printing. They don't want to take the material from Earth. So they're using this material to build constructions like this. So they have gone so far ahead. Okay. But we in COVID, we were like astronauts like this, trying to treat patients. This is our dear friend, Dr. Prakash. He was forcing us, me, Karthik, Nandini, all of us, you know, to go get this material from 3M. Wear this, please don't get infected. Okay. But when it comes to 3D, we are technologically very far. Okay. So let's see the next presentation, back to dentistry, how we are, where all we use in endodontics, your 3D printing. Okay. So let's begin first is, what is this 3D guided treatment? Okay. I divide this 3D guided treatment into static and dynamic. What is static? You have some guide or model at your hand. Dynamic is like your endoscopy. What you see and do it like your laparoscopy. That's the difference between your static and dynamic. So let's just see whatever I have told. Let's just revise the whole thing. Now you get a patient with a calcified canal. What do? I go with a CBCT with a particular field of view, whichever small one. Okay. Then if you have a laboratory scanner or an intraoral scanner, scan your cast or scan your mouth, okay, and then send it to them. Then what happens? You convert your DICOM format into a STL format. Those things will be done by the service centers that you are sending, okay? Then they will virtually plan what you need. You need to talk to the engineers or the doctors there, and they will plan accordingly, okay? Then you get a static. What is static? You get your additive 3D printing models in your hand, okay? Second one is dynamic. So this I will, now today's presentation after second half is only static. Okay. So let's see what is dynamic before I go to static. Nothing, same planning, same CBCT, same, they will plan in computerized virtual planning. And here, what you do is, there is a camera attached to the handpiece. Okay. You can all go see the net Navident, one of the companies, they connected to this. Okay. So you can see it in the monitor and do your root canal. Suppose a calcified canal, I want to know how much to go inside or anything, you will see it live and do. Okay, this is dynamic navigation. But today's topic is going to be in static endodontics. Okay, static guides. So what are the software? Some people have asked, what are the software used? Just to know, right? So here from DICOM to STL file, what are the softwares, the wherever you're sending, right? They are doing. Is your so many, you have Materialize, you have Blue Sky Bio and various other softwares. Second is you want to cut, you want to see where the length is, you want to see the length of the lesion, you want to see your length of your tooth. All these can be in a different, you can have an ExoCAD, okay? Then this is virtual surgical planning. Whatever these people have is all these things from 3Shape to Materialize. So these are the software names. This is totally a laboratory process, okay? Now, what is this static 3D printing? Okay, it's used in various things from drilling and cutting guides to OMF implants. Now, I will show you all one by one. Okay, where do we use 3D printing? First is in our subject, okay? Where all it is used, study tools, endodontic access, and surgical guides. What is study tools, okay? So for any patient educational models, you want to go show them you have a periapical lesion like this. How much ever you X-ray, you tell, you will not know. But if you could show this model, you can really convince a patient of this. The second one is you want to learn courses. Many people are printing tooth to train the postgraduates for the curved canals, C-shaped canals, anything they want. They've been trained accordingly. They send these models here and then they work on it. Okay. And the third one is endodontic. The second one is endodontic access, the most important one. From now on, it's just a clinical presentation. Just see, no notes, nothing. Just see the various cases where you can use 3D printing. Okay. Now, this is a case of calcified canal. Now, 10 seconds you think, now they have gained the access here. Are we right or are we wrong? 10 seconds you think in your mind, I will tell you exactly what is happening. Okay. So now you see, I put the CBCT of this. See what happens. You look straight. It looks very straight in a X-ray, but in a CBCT, we have perforated it. Okay. This does happen even for an experienced hand, sometimes in a calcified canal. Okay. So here we go to static guided endodontics. So the first case that I like to put is going to be a calcification. Okay. Calcified canal. Now this patient has come. Now see, this is a calcified canal. Absolutely in X-ray, you can't see any kind of canal over here. But when we take CBCT, you have an apical canal with a periapical lesion or a pathology, right? So how do we handle this? So you send a digital impression, whether an intraoral scan or a model scan to them, okay? They will virtually plan, give the bird that you're going to use the size to them. They will create, the engineers will create a path and they will give it to you back. How do they give it to you back? If you're a first person who are going to use a stent with a sleeve, they will give you a tooth like this. This central incisor will be calcified till here and an apical 1/3 will be a canal. Same. Then they will give you a guide otherwise called a stent with a sleeve. Okay. They will give it to you like this. So you place the stent with a steel sleeve over this tooth and then you do an access opening like this. Once you place an access, open and check whether you are on the right track. For people who are starting first, I'm teaching you this. Check whether you're on the right track. Let us see how they have done clinically. Okay. Now they've placed the sleeve in this calcified canal. They've used a burr, opened it up. Then they use a long shaft round burr. I'll give you what names. They go inside, locate the canal, and they're working that. Okay. So some burrs that they've used, I've just given some example from Dentistry. There is Ellen burr, there's Muller burr. They've used with different sizes are there. You can choose whichever company based with, but a long shaft, slow speed handpiece, preferably for learning at the beginning and to go to a long length. Okay. So this is what is called as a stent with a sleeve. Okay. We use this for a calcified canal. Now, second case. Now, this is a case done by Dr. Velmurugan and Dr. Nandini, the speaker behind me. So here is a case. Okay. They've used a stent. You can even use your rubber dam. There is absolutely no problem. Your stents are made accordingly. They've placed. See, they've made a small opening, access opening. They have done their working length and obturated. So calcified canals is no big thing now because of this digital technology. Okay. So now we go to molar teeth. How do we handle a molar teeth? Same concept. Okay. Now this patient comes, they have obturated. Maybe somebody couldn't identify this canal. They've left it like this. So how are we going to handle this case? So first you send it for a CBCT. But this means somewhere in the apical 1/3, there is canal. Apical 1/3, there is canal. So what do we do with this? So here there is an apical, okay? Now you send it to them. They will virtually plan. They will know where to put the guide, the angulation of the stent, and they will give it to you. Now see, there are two openings, mesiobuccal and mesiolingual. You can't change the angulation inside because the hole is correctly tinked for the what bird that you have given. Here, this particular article, they have used a neodent drill for temporary implants. Now they have located the canals and obturated. So this is how calcified canals are being used.
It's 10:15.
Okay, sorry. Types of access cavity. Today we come we've been studying, when we studied only maximum traditional cavities or a caries-based cavity or a restorative-based cavity. But today we are learning different names, but I've taken the basic given in IEJ, which is your conservative by Clark and Kadami, and your ninja axis, which is your ultra conservative, and your truss. Just imagine us doing such small cavities. Sometimes we don't locate the canal when we do a traditional itself. And imagine locating canals like this ninja, and here you don't even make an axis, just at the point where you have to make your canals. How are we going to handle this? Is there any way for us as PGs or endodontists to learn this? Yes. Now we will see this, okay? See the endodontic guides given to you all. So you place the endodontic gap as minimal as possible, they are able to do. Now, I'm not going into comparing the pulp removement and the fracture resistance because we have done a lot of studies, but nothing. But this is just to show you all guided access cavity can be done for cases like molars and incisors, which is having a truss or you want to do a ninja access cavity, very small or that. Okay. Now, I'd like to show you a case done by Dr. Nandini and Dr. Vel Murugan. See, this was done 2-3 years back. Sorry. Back, and here you see how this guide was given to them with 3 openings. Okay, so they could do it and they obturated and the case was success. So here it is, we've just given us some easy ways how to use technology to get things done. Okay, so next thing for an PG endodontic PG have to know about what is inlay guided endodontics given in your journal. Okay, this journal is a 3-dimensional inlay guided endodontics. Okay, now we go to this inlay guided endodontics technique. What is this technique is under microscope. Okay, now this patient, they wanted to do a treatment of 7, a retreatment. Okay, so retreatment they wanted to do. They went and they couldn't. See, it's here. They have now opened it up. They could not locate the distobuccal canal. Imagine this way. Simple is to extract and put an implant would be a clinician's thought, but we cannot think like this. We want to save this tooth somehow. So what is it? We take a CBCT and here Pavam, and they were doing it under microscope and they have perforated the canal. They've tried all their best. And I'm so surprised they've written, even after 2.5 hours, the rostral bruise was not found under a microscope. I really don't know, but this was there in the article. So I had put it, okay? Now CBCT is taken. Virtual planning is done. And what do is, instead of making, they cannot make a full coverage stent, right? They cannot make a guide. So here they used an inlay form, a resin inlay, slightly temporally luted it. Here you don't have to drill. They made a 0.6 millimeter channel right into where the distobuccal canal is. Okay, the distobuccal canal. Then they put the instrument inside, located the canal. Once they located the canal, now you can see they could locate the distal canal. Okay, they obturated, they even put a post and a crown. Now, I'm not saying the success, but this is a way our digital technology helps us to identify various cases. Okay, so that is inlay guided. Next thing is, and every PG gets to do in this 3 years is at least we do 2 or 3 cases of dens invaginatus. With knowing or without knowing, it is a compulsory, we do it, right? Every PG does. Now we go. So just for the first year PGs, if anybody is there, I like to tell, there are, all the 3 types of indens invaginatus. A small enamel-like invagination, which doesn't cross the CE junction. One which crosses the CE junction as a blind sac, but gets connected to the main canal or no. Third one is it opens into the periodontal ligament. Fourth one is apical canal. I will just show you how digital thing helps you to do this. Okay. So first one is conservative management of type 2 dens invaginatus. Let us see how. Now this patient has come. Okay. They wanted to do root canal in 1-1 and 2-1. When they took an X-ray and a CBCT, okay, they found dens invaginatus in both. Can you see a blind sac? So type 2 invaginatus inside. The main canal was deep infected. So they wanted to fill this up. They didn't want to touch the main canal. Most of the time when we didn't have this 3D. So we have messed up many invaginatus cases. Okay. So here was virtual planning sent to the lab. Use whatever burrs that you want to use, you need to specify with an intraoral scan or a model scanner they have sent. See, what do they do? They did a guide and gave it to us. Okay. This guide was placed with the burr. What they used was MI45 money burr. So this was placed, and this was, I mean, your access was prepared only for the invaginatus area. See here, the main canal is not opened at all, touched, only this, sealed with an MTA, so that this doesn't spread any infection to the main canal in future. So this is how type 2 Ehlers was handled. The next one I like to show you all, a guided endodontics with multiple dents invaginatus. If you get a case like this, how will you manage? Okay. So first one is, see this case, they have come for 2-1. Now here there's a 2-2 was such a huge periapical lesion is there. Okay. Can you see in the CBCT, there are 2 invaginatus, type 2 over here and type 1 over here. And even in 1-2, there was 1 invaginatus. Okay. Now this multiple invaginatus, how are you going to handle? Here, the main canal is also infected. So here, how did they try? They took a CBCT, sent it. They sent 3 different sizes, whatever you want, the size of the burr specified. They did 3 guides, okay? 1 for the type 1, 1 for the type 2, and 1 for the main canal. They placed the stent, opened individually. So let's see how did they treat it. First, when they placed the stent, both the invaginatus type 1 and type 2 were sealed with MTA. Once they seal it, they place the third stent and they open the main canal and they have obturated. So you don't leave any source of infection. Now, when I see this case, I always think we PG should, or we endodontists should have, either we have to have this patient, we should have patience and perseverance to sit and do all these things. Okay, 3 things, 3 P's we need. We need the patient, patience, and perseverance. Okay. The last case is dens invaginatus type 3, the most difficult one we see. Now, when this patient like this has come, okay, they have taken a sinus, they have traced it out. It was looking. Now, if we didn't have any CBCT, what could have been the treatment in your mind? Without seeing all this, what would have been treatment in this? I would have definitely done to check for vitality, but still I would have had a doubt that it is involving the lateral incisor. But here to the surprise, this was your invaginatus and the main canal. The main canal was vital, only that this was infected by seeing the CBCT. Okay, so what do you do in such cases? Get your prototype preclinical training. You open it, you have your model in your hand, you learn it first, how you place inside, how do you seal it with MTA, and then you see that they didn't treat the lateral incisor, they didn't treat the main canal, only the invaginatus was treated and the healing is happened. So what a beautiful case. Only little thinking, little patience and perseverance, we can definitely get a good healing. This is the 3 cases, okay? And the final 2 cases is going to be transplantation. Now this transplantation is again one surgical case that we do as a postgraduate. So does 3D printing and digital thing, does it help? Yes. Let us see how does it help, okay? What are the main factors in success of transplantation? Preservation of periodontal ligament cells and your extraoral type, right? Now I'll give you a case presentation, okay? Now this is a one case where they wanted to do extract your 7 and place the 8 inside, okay? Now 8 will be definitely a larger size than the 7, yes. So here what happens, they've extracted 7. Now I want to do the extract even the 8. So 8 and 7 is at the hand. Now how are you going to place the 8 and 7? You take the 8, place inside. Every time you keep trying to make it big, and then you fit in the 8 in the 7th place. This is what we do, okay? Now what digital technology has come is the transplantation. They say that every time we put and try this, lot of periodontal ligament cells are we losing, okay? We are losing the periodontal ligament cells. So what do we do here? Now they have created something called CAR, that is computer-aided rapid prototyping tooth replica. Even before you could go in for your transplantation, suppose you want to do the same 8. The 8 tooth is in your hand like this. You take this, you try it. So you don't keep taking a natural tooth and putting it inside. Okay. This will be tried. The carp will be tried and then you place it. Now I'll give you a case presentation, which is given in IEJ. This article is nice for a 3D printing. Any PG, you can please read this. Okay. Now this is a case of cervical resorption 2-1. Okay. Now they wanted an extraction of this cervical resorption. Okay, they have done a root canal some 10 years or 16 years before, 10 years, I think, and they wanted to, 10 years or something. They wanted to extract because of cervical resorption. They wanted to transplant 3-4 to the place of 2-1. Okay, they have done a study and they've wanted to place 3-4 in 2-1. Now, how do you do this? Here itself, they've done all the crown and kept ready. Virtual planning was done. Temporization also was done ready and kept ready. Okay. Now what you do is, now is CAR. I told you the computer aided rapid prototyping tooth is ready along with the guide, Now this is ready. So now what do you do? Once they extracted the tooth, okay, this CAR tooth was tried in. You don't have to try your natural tooth from lower premolar and go in and try. Your carp is tried, placed inside with resection, and that your temporization is given immediately. So this is how 3D technology helps. So you can use your guide and this tooth for your transplantation. Okay. And the final, and you're going to surgical guides. Okay. So endodontic microsurgery, you know, right? Or targeted osteotomy with root end resection, everything we do, sometimes we open, we locate the canal. Now it becomes more easier with 3D technology. How is it easy? Okay, now this is a case done by Kavita ma'am 2 to 3 years back. So this is a case with a periapical lesion. They wanted to do a surgery. So they had sent your CBCT scan over here. Okay, the virtual planning or a digital planning was done. Okay, now this is placed and the model is also given to you all with this for even you want to practice, you want to see where, how you're going to do, everything is there. Root resection height, you can see the root resection tip here. Okay. Here they have placed it and they have done a surgery here. See, surgical, the root end resection is also done through the small opening. So you limit your access, finishes fast in time. Your good instruments are planned right before you plan your surgery. So your surgical guides, not only for anteriors, even posteriors guides are all planned. Even if it's a double, it's planned. Okay, you just have to talk to your service centers. They will do these guides and give it to you all. Okay, so this is the article. I've taken all these pictures, you can read it. Okay, now this is one case which I had got. This is a periapical pathology. I think they did a twin obturation. They did inside the canal as well as outside the canal. So it was a healing lesion because you could see all here, there was the it was a granulomatous, but the patient had infected again. There was an infection again over here. When we opened to see a CBCT, there was a huge lesion and palatal bone was getting breached. So you design your own, whatever you want, you can design your own 3D design. So here what we did is, we opened it, see, we designed the lesion in front and a palatal stud so that I don't perforate your gums. So this is totally your creativity. There is absolutely not sticking on to anything. Okay, from a PG point, they started off like this, and from one side they went to the other side. Palatal stud was there. They removed the twin obturation and then they placed biodentin, and now it's 6 months follow up. It's not there because patient is left abroad. So this is how you design your own stents. It does not have to follow your own. You can design your own stents. Okay. And finally is fusion of teeth. Fusion of teeth. So every time when we come, this is a lovely case of a mandibular second molar along with a paramolar. How are you going to train up this? How are you going to even do this? In such cases, bench training is very important for postgraduate students. They need to have the model in the hand, check, learn before you attempt such cases. Okay, so let us see one case which has both, because I wanted to finish it together. I put a hemisection and an auto transplantation together, how you do the in a fusion teeth. Okay. Okay, this is a girl child. The parent had come with only one complaint, is aesthetics.
It's 10:30.
Okay, This is aesthetic. So now what happened? You have two teeth attached. Even you can see canine is not erupted, premolars are not erupted, but they were bothered about aesthetics. So what did you plan? What will I plan? Or what will you plan? Let's see what the doctors plan. When they took a CBCT, it was fused from the coronal till the middle third. Okay, it was fused from the coronal to the middle third. Okay, now what do they plan? Let us see. They wanted to hemisection both these teeth, the supernumerary and the lateral. Okay, this buccal tooth which is turned this way, they wanted to discard it. They wanted to bring this palatally placed 1, 2 to the buccally, the labially. Okay, and we'll see how the autotransplantation and hemisection can be done. Now they send the CBCT to any center with the scan impression. Now they made a small little slit for the hemisection, okay, which is around 6.5 millimeter buccolingually. So the burr has to go 15.2 millimeter inside to separate those two teeth. Okay, let's see how they did. They placed the stent. In that little opening, the slit, they used their burrs. They split it. They discarded the buccally placed tooth. The palatally placed, now they see how autotransplantation is done. They did not use this tooth because they wanted to save this PDL, periodontal ligament cells. They used the car. Okay, a tooth was designed before it. They try it, place this tooth inside, and they place the fiber ribbon and they placed it. So here I have a very good follow-up. Look at this, the study they've given, 2 week, 3 months, 6 months. It was still non-vital. So they went in to do the root canal, waited, and look at the follow-up. Look at this crown, which was here. As the canine erupted, moved to its place, and the aesthetics was restored. So this is a case of hemisection and thing. It is our design. You need to design. You need to sit and see every case. Okay. So that is over with the stent sleeve. One more, just because of PGs who have this, you need to write, if a topic is given to you all as endodontic guide or 3D printing in endodontics, what do? Okay, you first write whatever you saw was sleeve. But I have one article which says sleeveless, but very, it is an expensive affair. First, you all can try. So any guide comes with a guide with a sleeve like this, right? With a metal sleeve inside, or without that also. Here there is, because we are students, we are here to know. So JOE is given in 2020, sleeveless ones. What are the sleeveless ones? See, this is a premolar, pretty long tooth, okay, curved tooth. So these people wanted to see, and a little limited mouth opening means you have to see the tooth, right? So these people wanted to design something different. That's it, okay? It is your creativity, I told. Here, they made a splint like this. They made a 2 cylindrical bars like this. Then they made an adapter like this. They kept the adapter here, and they did the premolar. Now let's see. They opened the axis, obturated it like this. So it is your creativity to know what is what. So there is sleeve, stent with sleeve. There is stent with sleeveless stents. So this is what is used in endodontics. Okay. So resorption I'm not touching because Dr. Nandini is going to speak, because Madam has got an award, JOE 2022, the best award. She has used 3D technology for this. And I'm so happy for my friend. So she will be speaking on this. Okay, so I'm not touching on this. So the last slide that I'm going to cover is, hope this is a break time slide. Because they said general practitioners are there, add something to it. I'll just show you all where else 3D technology is being used now. Okay. So what is 3D bioprinting? Any paper doesn't end without a recent advance, right? So you can write about your 3D bioprinting. What is 3D bioprinting? Now with this thing, they make organs, they make tissues, they make anything with it. And now they've tried pulp dentin complex. Dr. Mahalakshmi ma'am, whom I look upon to her so much because she does a lot of work in scaffolds. And I love to read her papers. But here 3D BIM, I'm not going to give an entire thing, just an outside for a PG to know what is 3D bioprinting. So here, 3D, what is used for regenerations? You have cells, you have scaffold, and you have a signal biomolecules, right? You need all these three. So I'm not going into depth of this. You have your cells, you have your scaffolds. Now in this scaffold, only the little different is your bioprinting. You have your indirect scaffold. That means you have a scaffold, right? Like a mat in which the cells are being impregnated. Okay. Whereas in bioprinting, the scaffold as well as the cells are mixed together. The hydrogel and the cells are mixed together and injected through a nozzle to create whatever organ that you like. A heart is made, a heart cell, a valve is made, a pulp dent. I'll just give you now. This is called as bio-ink. The cells and the hydrogel biomaterial, that is your scaffold, is mixed together. And this is a small, this is the apparatus which is used to print organs. Okay, this is called as bioprinting. Is that used in our dental endodontics? Let's just see. This is just an idea where they have combined together from the bio ink. This is the 3D printing, whatever shape, whatever cells, where it has to be, endothelial cells in center, odontoblastic cells inside, whatever you want to plan, you can plan and then create a thing. Okay. So one little study that I like to put here is for you just to get an outward thing, what it is. See, here is a scaffold. You have your growth factors, you have your stem cells, you have all this together. Okay. Now they are placing into a pulpectomized tooth. Okay. This is sectioned and placed in a small little animal. Okay. So here what happens is after some time they realized a dentin pulp complex is formed. Okay. So this is called, this is regeneration used with this bioprinting. This is what bioprinting, using a computerized virtual planning, you create your scaffolds and your gel to form the organ that you like, to form the tissue, especially pulp. Here, the periodontics people are using it for gingival, everything. We have also begun to use now for pulp. Okay, so that ends with my endodontics. So after this 5-6 slides, you'll only see what's used in other fields just to complete it, so that because if you're a private practitioner, okay, see what is it used? It's used for various models, splints, you want to use stents, guides, anything is used, okay? In oral surgery, what is it used? Same thing. We have actually learned it from them. They were the first people to use an implant guide. Now it's become guided implantology has become so good that everybody is learning it and doing. Okay. Next is patient specific implants. Suppose for a patient who has lost his entire, this COVID has, I was so shocked to see many things as mucormycosis. You know, they've lost many maxilla up to your orbit. See the way they have replaced in oral surgery. These are the various steps, and immediately patient even gets their denture. Okay. So this is what is done in other things. That's all I'm doing. Your TMJs, your glenoid fossas, okay? Your customized temporomandibular joints have been done because of 3D. Okay. Coming to orthodontics, just to finish it, is your alignment of teeth. Your aligners are based only in 3D technology. Okay. Your lingual orthodontics and your indirect bonding. Okay. In prosto, where all it is used, it's used for you making your 3D dentures are being used very quickly. The dentures are being given. You've made 3D printed metal bridges, your temporary crowns, your cast metal framework. So I end by this just to show that all these are done by 3D work. Okay. So here is, I complete my presentation by saying that 3D is used in every field, orthodontics, endodontics, anything you name it, 3D is there. But when do we use it is in your hands. Future is in your hands. Every dentist have to try and use technology to learn that we are not behind anybody else. Okay. So with the question asked today to all the PGs, will 3D technology change everything? Yes, only if you are ready to change, take the big leap, learn cases, read your articles and do it. Okay. So I'll finish it by saying, if you can't fly, then run. If you can't run, walk. If you can't walk, then crawl. But whatever you do, students, please keep moving forward. By Martin Luther King. And I would thank STARS for helping me with this pictures and all these slides, which they've been doing. I thank the entire team and Dr. Arjun for giving me cases. Thank you all.
Thank you, Hannah, for that wonderful presentation. Now we are open. Thank you, Hannah, for this wonderful presentation.
Thank you, ma'am.
Now we are open to the question and answer session. Over to Dr. Adira and Dr. Sudarshana.
And I just want to know something more on that sleeveless.
Yes.
Can you please repeat that slide?
This is the article from 2020 in JOEPA. Okay, now see, usually what do we do is we get a sleeve. Whenever you have a guide, you have a sleeve like this with a hole here, right? So this depth itself becomes a little length. Nowadays, we are getting people, we are giving a thing without sleeve only. Most of the time, we are giving it just adjacent to the tooth. These people have designed such a way, called as a sleeveless guide. Okay, that is just a, what to say, it is your own creativity. Okay, here, see this, this was a pretty long curved tooth. They wanted to visualize the tooth before doing. If you place the stent on top, this you cannot see the tooth. Okay, normally when you place the guide, how does a guide come? The guide sits on the tooth. But here, what do they do is, they'll see, you can see the tooth. Okay, here they made two sleeves like this. So this adapter, they have done adapter, which this handpiece fits in there like this. So by seeing the tooth, you can go ahead. Usually stents will cover the entire tooth. Here in the stents are not covering the tooth is exposed. They just made this design like this, okay? And they have placed an adapter here and both the sides has been fixed. And now they're doing the opening like this. This is sleeveless. This is only one article which is given a modification. So I just told for PGs, but it is very, very difficult to do. Try this. This is just on a maybe a trial basis you can try, but it's better we go with your this one, this kind of a sleeve one, or like how I had told you what these kinds of any kind of guides. See, this is a guide. No, these are the guides which has been given. Now we are giving even a single tooth guide, like how we did for single tooth guide with maybe a support of the next adjacent tooth. See, these are all single tooth guides. Okay. These are all the guides. Now you can see this Dr. Vail Murugan and Nandini have done. This is a guide which I think 2 teeth were involved and they could just place it on top and do it. So your rubber dam is also there. Any other question? Okay, Karthik. Dr. Karthik.
Can you please explain about CARP once more?
I can't hear you, ma.
About ARP transplantation.
Yeah. You want to know what is CARP, huh? Am I correct?
Yes, ma'am.
Yeah. Okay. Okay, now see, for example, right? Now this is the case. Now I've extracted 7. Now they want to place this 8 inside. The 8 is quite a solid big tooth, right? So this 8 tooth will have a lot of periodontal ligament cells here. Now you drill the tooth in the extracted socket. Now you need to use a drill to fit this tooth inside this. Every time you put this tooth inside, remove it, and then you irrigate it during drill, how much of periodontal ligament cells that's stuck over here goes off. So they want to avoid this. They do not want to use the extracted tooth for a trial into the other area. So what do is, before you head itself from the CBCT, they print that 8 and give it to you in your hand. Okay, it's like a pre-trial. You have it in your hand, the 8. You don't touch the extracted tooth at all. So for example, in the next case, here, they would have made a computer model of this premolar. Once they extracted this, okay, they plan everything. See, this is a tooth made of resin, the same shape. Now they will use that, try it inside and make the drill. Okay, once they do the carve, then they will seal it. Okay, so it's easy and the temporary is already ready even before you finish your treatment. That is only scar. Okay, am I answering to your question? Dr. Adira?
It's 10:45.
Any more questions? Adira Sudarshana?
Ma'am, the next question is, do we have to instruct the lab person about a bird diameter, ma'am?
Of course, yes, ma. Only then the sleeve can be made. Only then the opening will be made accordingly with the angulation. Okay, all your
Ma'am,
birds.
how we have to select the diameter of the bird?
No, ma, you can see the most of
How
them.
we have to select that?
Vernier caliper if you have. Otherwise, just give your bird name to them. They will find and also they will do it. You have all your bird
Okay.
diameter with you. If it is there, right? We know it is. Now I've given you certain bird length, right? Like so for
Yes, ma'am,
example, if
L
you're
and
using it, yeah, L and bird, Muller bird, you can use M, everything is given, ma. You whatever, but suppose you want to use a small calcified area, you can use your half round bird. If you're giving, give that. They will know you'll know the diameter of it, right? So it's,
Yes,
like
ma'am.
that. It's just whatever it is, you need to give your bird.
Ma'am, the next question is, in addition to root canal treatment, how much we can charge for the patient if we use guided endodontic sleeves, ma'am?
This is I don't have any. That's your call, my dear. I don't know. You wherever you're sending, how much are they charging? This is an educational forum, so you don't have to charge extra. What is your charge for your whatever is your guide stent? You charge the patient extra. That's it.
Okay, ma'am. Ma'am,
Like, in case of calcified canals,
Yes.
suppose if you do the guided access opening, do we need to take CBCT after the completion of the after negotiation?
By an X-ray itself, you will know. Why do you want to expose the patient again? When the patient you have a success in your treatment, when you have located your two canals, maybe X-ray would be fine because why expose another time CBCT? But one thing, if you have a periapical, now I think that Dr. Nandini will tell. If you have a big periapical lesion, okay, and you have done your endodontic access and everything, and you want to see after 1.5 years, you want to see healing, okay, and you want to send for publication, they do not accept, JOE doesn't accept if you don't have a post-treatment CBCT. Once only if you compare the first CBCT and post-imaging. I think she will explain to you because that's why I kept the resorption slide free because she's done that case and got the best award. I don't want to tell, but that's the water. You have to compare both and only send it for publication.
Okay.
ma'am, the next question is, the software which is used or free or we have to cost it more,
It's
ma'am?
very expensive, dear. Frankly speaking, it's very expensive. It is expensive. That's why we send it to service centers. Otherwise, we'll have. But many institutions are buying, especially oral surgery. If they have, then you all can also use it up and learn. Okay. If the oral surgery department has, we can use. But most of the centers where you send no to use it, they have all these things. So they will use it. It is expensive.
Yes, ma'am.
Any other questions?
Ma'am, can you hear me, ma'am?
Yes, ma'am.
Ma'am, while performing the using a bird, how much deviation we could expect, ma'am?
No, deviation is the channel is angulated. You can't deviate. Right? The channel is created to do a CBCT or through your CBCT images, the channels are created. Okay, so you cannot change your angulation. If you change your angulation, you will definitely if you try perforating through the resin and going out, then it will be a perforation. If you cannot change your angulation, you go with the sleeve hole straight inside because when you use it, you will know it will be angulated. All your openings will be angulated to the exact area. First, it is difficult, dear. It is difficult to use. Once you get used to, that's why I said the first slide, please, before we use, I want all of you to go with your tooth like this. Okay? Tooth model, get your tooth model in your hand of that particular tooth with this stent with a guide. You see the tooth is here. On top of the tooth, you place this guide. Try first. Feel it. Feel with your hand how you're going, whether you're wrong. Remove it and check whether you're in the right path. Only then you proceed on to the patient. Okay?
Is there any specific diameter? Should be like a smaller diameter?
No, it depends upon the X-ray and the CBCT you see. If in a calcified canals, I've given you all the depth of the burrs that is used. Any long shaft, small head burrs, if you're scared, small head. Here, for example, you have 6 variety, right? Most of them have used the yellow one. That's why I've given the head size over here and the tip size. I've given everything here. The head size is here. Okay? So you use it here. See, slowly they're going inside. So you can deviate only because it is only that hole. You can't change your direction. So it will go in like this.
Okay, now we shall have a break of 10 minutes and then we will get back for Dr. Nandini's session.
Thank you, ma'am.
And a tea break.
Thank you, Dr. Karthik. Thank you.
But no tea.
You send the tea. Thank you.
Thank you.
Ma'am, one more question.
Yes.
Yeah. In case of canal aberrances like normal variants,
Yes.
trifurcations, bifurcations at the root apex.
Yes.
Yeah, can we use this one? And another is, can an endodontist only do, or a general dentist in a clinical practice can do this without an endodontist help?
Many general dentists are undergoing guided endodontic courses. Okay, then only you can do. You cannot do directly. It is not easy for us to do. That's why I said even an endodontist, if you're starting, you need to have a model in your hand. Try.
Yeah, yes.
So that is not easy.
Yeah, I had a doubt whether we ourselves is a nightmare or like what is inside we don't know. Like blindly we go. So I had a doubt whether general dentists can use it like how we are trying for a cats.
Until undergoing training, it's difficult.
Yes.
It is difficult.
Yeah, okay.
Because recently I wouldn't tell, one college had used perforate, but they said, ma'am, it's not going in. The burr's getting tight because it is difficult even for us. So it takes time.
Yes. Yeah. Okay. Thank you.
Thank you. Thank you, ma'am. Thank you, sir. Thank you, Dr. Karthik.
Shall we meet after 10 minutes, Hannah?
Yes.
Okay.
Bye.
Nandini?
Yeah, tell me, Karthik.
We'll have a break for 10 minutes and then we will start with your presentation.
Yeah, sure. Done.
Okay.
Now I request Dr. Deepa to introduce Dr. Nandini. She's not coming.
Dr. Nandini.
Hi, Karthik. Am I audible?
Shall we start? 1 minute.
Yeah, we can. So because I just changed my audio system, is it audible?
Okay.
Okay, I request Dr. Deepa to introduce Dr. Nandini Suresh.
Happy to introduce Dr. Nandini ma'am for next presentation. Dr. Nandini Suresh began her teaching profession in Meenakshi Ammal Dental College. She is a certified member of Indian Board of Endodontics since 2017. She was the associate editor of Journal of Conservative Dentistry from 2008 to 2016. And currently, she is the editor-in-chief of Endodontology. Her contribution in the field of research is enormous, with about 50 national and international publications to her credit. Her subject of interest includes dental trauma, root resorption, regenerative endodontics, and nanomaterials. She is a reputed speaker of national and international forum, and she is here to enlighten us on root resorption. Welcome you, ma'am, for your today's presentation.
Thank you, Dr. Deepa. Could you please enable for sharing of the screen? Still not able to share my screen.
One
Ma'am,
second.
the other system name, ma'am.
Sorry?
One minute. But I think be able to do now.
Now I'm able to, yes. So this is my screen. Is my full screen visible?
Yeah. Start.
Good morning, everyone, and thank you, Dr. Deepa, for your kind introduction. And first, I would like to thank KSRIDSR Dental College, Dr. Shabina, and a special thanks to Dr. Karthik for this particular platform to share with Dr. Hannah on this particular CDE program. Actually, while preparing for this particular topic, it was very nostalgic because it was two things. One, I was presenting with Hannah, and she's one of the best person who you can learn from. She has a very nice way of teaching things, and I'm still scared after presenting her. And the first picture I specifically put because it is Karthik and Hannah 20 years back. And this is our batch, and Karthik, Hannah, and my batch were the three only government batches that was in Meenakshi Ammal in the college at that time. And as you see, we are a very closely knit pack. We still are. And it's a very lovely platform. I really thank you, Karthik, for this presentation and to do with Hannah. So I'd also like to say that I'm switching off my video because I'm presenting through my data. So kindly excuse me for that. So today's topic, I'm going to deal with managing root resorption. So the first question is $1 million question, whether we encounter this kind of cases in our regular practice. Why do we have to know this, and how is it really going to affect these kind of cases? Why don't we just extract, put an implant and have a permanent option? This could be the first question in most of our minds. Yes, we do encounter this very frequently, up to 20% of the cases which I'll be explaining. But why can't we just extract and put it? Because when you see trauma and orthodontics is one of the main causes for these kind of resorption, particularly the inflammatory root resorption, which can happen in a very young age from 6 to 16 years of children because of trauma. And these is a clinician's nightmare. So what happens? Extracting these tooth can affect the growth of the jaw, aesthetics, and a permanent replacement in this particular age may not be really feasible. So these kind of cases, when we encounter, we have to try to hold it into the mouth for at least some duration of time and allow healing so that the growth completes and there is some kind of permanent option that is available. So let's start, like, what is the incidence of the root resorption, particularly after a avulsed teeth? This particular group has worked on the incidence of root resorption, and they have found that after an avulsion, up to 50% of the tooth undergoes a replacement root resorption, which is followed by the inflammatory root resorption. And they've also insisted that most of intrusive luxation causes these kind of inflammatory root resorption. And definitely awareness of the incidents that should be there with both the clinicians and also the patients so that they can prevent it or they can also treat it accordingly. Root resorption could be physiologic and also be pathologic. Physiologic is the deciduous tooth where it undergoes resorption, but it is pathologic due to various lot of causes, and it results in the loss of dentine, cementum, and also bone. And this is mainly due to the plastic activity of the odontoclast of the osteoclast. So before going into the treatment and the prognosis and of this particular kind of resorption, let us see why it happens. So we have to understand a mechanism of resorption first. And only then we can see and look out for the clinical features and also have a good treatment planning. For postgraduates, this is more for postgraduates. So this particular article by Eleanor et al. Is very good in explaining the cellular and the molecular pathway of resorption. In nutshell, I'll try to explain what happens in the resorption. So we have the hematopoietic cells in the blood. In the first phase, when there is either it has to differentiate from a semi-quiescent stage in the lymphoid or a myeloid progenitor cells. What happens in the presence of inflammation or pro-inflammatory factors or colony-stimulating factor, it predominantly go into the myeloid progenitor cells, which in the presence of rankel or colony-stimulating factor, which is all pro-inflammatory factors, which will become the macrophage progenitor cells. These macrophage progenitor cells has to convert into a pre-osteoclastic cell. So what happens? They have in the surface something called as the rank-L receptors. So they bind with this CSF and they convert, or what happens is once this binding happens, they all fuse into a mononuclear. Individual cells of mononuclear becomes a fusion. It fuses to form and polarizes to form a single fused multinucleated osteoclastic cell. So how can this be stopped? It can happen either as a self-regulatory mechanism or through other mechanisms. There is something called as the OPG rankel decoy. That is, there is a protein called as OPG, which is similar, and it can bind to this rankel. And therefore, what happens? The usual inflammatory factors cannot bind. So since this OPG binds, so this particular ratio is called as the OPG rankel ratio. This, when it is increasing, what happens? There is a decrease in the resorption. Therefore, once this happens, the fusion of the mononuclear cells followed by the polarization gets avoided. So this is one way of stopping or arresting the clastic activity. So when I'm talking about clastic cells, so the two main clastic cells that we are supposed to know is the osteoclastic and the odontoclastic cells, and they're more or less similar to look at. Odontoclastic cells are slightly smaller cells compared to the osteoclastic cells. They have lesser number of nucleus and the size is also little smaller. So this is what I had explained in the previous slides. You have the conversion of the hematopoietic stem cells into the proliferation phase into the pre-osteoclast. It fuses in the presence of rankel in CSF1 and in When the inflammation is not reducing, more of Frankel is there, it becomes polarized. And there are interleukin-1, 6, TNF-alpha, they are all pro-inflammatory factors. It could be because of a trauma, it could be because of orthodontics. These are the pro-inflammatory factors. Once they increase, they become a mature odontoclast or an osteoclast, and they bind to the particular substrate. The one important thing here is they bind to the normally mineralized structure and not hypocalcified structures. So once they bind to the bone or to the dentine, the resorption activity takes place. But when we look into the question, which resorbs faster? Is it the bone or is it the dentine? It's obviously the dentine, if you see, because the number of cells that is getting attached to dentine is comparatively more. And we have something called as the podosomes through which the cell gets attached. So that has the actin ring, and the half-life of these rings are more for the odontoclast when compared to the osteoclast. And the number of resorptive pits that can form with an odontoclast is definitely higher than an osteoclast. And also the cathepsin K and MMP9, which I'll explain, is also extremely high when compared to an odontoclast. So therefore, when you compare bone and dentine, dentine resorbs much faster. So along with this, we also have to know the main culprit in resorption, that is the macrophages. We have two kinds of macrophages. One is the M1 cells, another is the M2 cells. M1 cells is called as the killer cells. That is, when there is pro-inflammatory TNF-alpha or nitrous oxide, which is increasing, it automatically increases the macrophage because this will remove the all the pro-inflammatory factors. So it is a natural mechanism that when there is an inflammation, the M1 cells comes into action. So once this M1 cells increases, there is an inflammatory increase, and the interleukins also increases, the rankle increases. Ultimately, the osteoclast gets formed and it attaches to the dentine and it causes the resorption. But when there is a delicate balance, there is something called as polarization. There is the M1 has to convert into M2. That is, when the inflammation is reducing, there is a shift from M1 to M2. M2 is called as the healer cells, which will increase the anti-inflammatory process and therefore increases proteins and interleukins and also the bone protein, the OPG, and the amylogenesis. These factors are very important for the formation of the cementoblast and the blastic activity. So once there is a polarization from M1 to M2, there is a increase in the factors that will increase the blastic activity and the reparative process can happen. So one most important step is once the clastic cell is formed, it has to attach to the substrate. That's called the adherence of the clastic cell. So how does it form? It's basically like a clastic cell in the presence of osteochondrin and the bone protein. It forms a lock. So once it forms a lock, this is called the podosomes and the ruffled borders. Once it forms a lock to the substrate, it forms a sealed environment into which, with the presence of carbonic anhydrase, which is pro-resorptive, it will increase the H plus ions, that is the acidic ions, through the proton pump. It gets expelled into the sealed zone. So this H plus ions will remove the organic component. So we have the Golgi complex and the other vesicles, which will release enzymes like the cathepsin K and MMP9 and other things. So that will be released into the area where it is already the organic component, the inorganic component is removed. So this will be the cathepsin K, MMP9, and all those things will remove the collagen and all those components, and all these things will be removed. These degradation products will be removed by the tartrate resistant acid phosphatase. So this lock is very important because once this is formed, the cells attach to this substrate and keeps degrading the substrate. So is resorption a self-regulatory mechanism is the biggest question. Yes, it is definitely a self-regulatory mechanism is existing. Why does this happen? When we have more of osteoclastic activity and degradation is happening, there is a lot of calcium that gets released. This calcium acts through the calmodulin and calcitonin proteins. They increase the tyrosine protein kinase. And what happens, as I said, there are two things. One is the hydrogen proton pump and the lock, that is the osteopontin. Both of this gets blocked. That is, osteopontin decreases and the proton pump is also blocked. So therefore, the addition of the clastic cell to the substrate decreases and the proteasome gets released. Therefore, once the lock is released, the plastic activity stops. This is also why we use calcium hydroxide medicament, because the calcium content acts on the plastic cells and reduces the plastic activity. Not only disinfects the canal, but when an absorption case, use of calcium hydroxide is very important. Therefore, we have to arrest plastic activity prior to the restorative process. So the next is, what are the types of resorption? There are various types. It could be either an internal, that is actually inside the canal, or it could be an external. Under the external, we have the inflammatory resorption. When we talk about inflammatory resorption, it does not mandatorily involve that there should be an infection in the canal. Yes, infection does cause inflammatory resorption, but there's also non-inflammatory resorption, like in the case of orthodontic treatment, where there will not be any infection, but still the movement of the orthodontic forces can still increase the inflammatory byproducts and can cause a sterile inflammation that can also cause the resorption. So under inflammatory, we have the cervical and the lateral. So when we see resorption, there is a lot of clinical manifestation, and also basic mechanism also differs between each of these kind of resorptions, and the handling and the treatment also differs. So today I will be predominantly and only be talking about external cervical root resorption, because by itself it's a big topic, and remaining type of resorption is beyond the scope of this particular lecture. So first, we're thinking about external cervical root resorption. We have to understand that it is a very dynamic process, and it is a very progressive nature, and it kills the cell. Once it initiate, the progression is very rapid. So to understand and to plan the treatment, we have to know what is the etiology and how it progresses. That is the pathogenesis. So this slide is mainly for the postgraduates, where these are the classic literature on invasive cervical root resorption, by starting from Heather Say's article, who's been the pioneer in working in invasive cervical resorption, followed by Patel's article and the position statements, and recently a group by Mavrido, who's extensively still working on this external cervical resorption. So as a postgraduate, I would recommend all the students to go through these couple of articles to thoroughly understand the invasive cervical resorption. Going on to the etiology, let's say used to compare a few causes before, but right now they have found orthodontics being the dominant cause for an external cervical resorption, followed by trauma, oral health, and other oral habits. Again, when we see just the type of two, predominantly it is the maxillary central incisor, whatever is the cause, followed by mandibular molars, and also then comes the premolars. The orthodontics is predominant cause, probably because the awareness of aesthetics and the number of patients undergoing ortho is definitely increased over the last couple of decades. And molars is again, maxillary central incisors could be accumulative of ortho plus trauma, but mandibular molars probably could be due to the reason of banding and other reasons. So that is why these kind of this particular tool is having more incidence. And when we see the gender, male and female does not really actually matter when it comes to resorption. Both are equally affected when it comes to the occurrence of CR. So in summary of the etiology, the slashed line indicates the incidence told by Dr. Hethersey, and the recent incidence given by Mavrido is in the block lines. We are able to see orthodontics way ahead than what was reported in 1999. And in 1910, they had not assessed a lot of other factors, but recently a lot of other factors has also been included into the causes. So predominantly it is orthodontics followed by trauma, oral health and malocclusion of the top causes, and also the parafunctional habits are the top causes that can cause PCR. So we have talked about what's the etiology. Now let's see what is the pathogenesis, how it spreads. So in pathogenesis, this article explains very well on how it progresses so that we can understand and also plan our treatment accordingly. There are 3 stages. So the initiation, absorption, and the repair stage. That is where it self-regulates itself and arrests the resorption by itself. So in the initiation stage, we have to see one main thing. There is the portal of entry. That is where the resorption starts. It may be very small, and like caries, it can also undermine your tooth structure from inside. So when there is a damage to the PDL, that is when due to trauma or due to surgery or due to scaling or any traumatic area where the PDL gets damaged and there's a cemental exposure or a cemental damage, or there could be a gap between the cementum and the enamel junction. So in those areas, when there is going to be a damage, it leads to bleeding and clot formation. As a natural way of healing, macrophages tend to accumulate there, and therefore the pro-inflammatory factors increase. Once that happens, there is a granulation tissue that forms. So once the granulation tissue forms, that becomes the point of entry or the portal of entry. Again, when the portal of entry, you have something called adjacent tissue. When the type of tissue that's seen in the portal of entry depends on the type of tissue that is adjacent to it. If it is going to be bone, you will find more of osteoid-like deposition there. If it is going to be a PDL, you will see more of cementum in PDL deposition there, and there is no tissue adjacent, and there's only plaque accumulation. You will see inflammatory granulation tissue here. So you can also see this is the portal of entry where you can see there is a calcified board-like tissue. This is very important because the presence of portal of the ability to feel the portal of entry during clinical examination and to see whether there is any bone-like tissue will determine what is the treatment we are going to do when the patient comes to us. Despite having a portal of entry which is sealed by bone, you can see that there is a lot of resorption that's still happening as a channel below this. So the other major factor is hypoxia, that is less of oxygen. This factor has been recently added as a major contributing factor towards the resorption progression. So what happens? Then there is a damage to the PDL blood vessel. This could also be due to orthodontic forces. There is, when the blood vessels gets compressed, there is a lot of hypoxia that's happening. Once there is hypoxia, it affects the metabolism of the blastic cells and affects the fibroblast, and therefore hypoxia leads to a lot of active resorption both in bone and also in dentin. So understanding that hypoxia is a major role in resorption, we have to make sure that in the patient with the active resorption, whether we have to look out for factors which is causing this hypoxia, like when there is a trauma from occlusion or there is an orthodontic ongoing treatment. So all these things has to be looked upon and it has to be relieved so that it will arrest the resorption process. Next is the active resorption stage. Once the resorption initiates, then it starts to progress unless the inflammation is stopped. So if you see this picture, there is a portal of entry. Once there is a portal of entry, it goes from the outside to the inside into the dentin and towards the pulp. You can have multiple portal of entry in a particular tooth, and we see that it does not directly invade the pulp. There is something called as the resistant sheet. There is a resorption resistant sheet here that's called the PRRS, and you can see that the resorption goes over it and underneath it instead of going directly into this. So this PRRS protects the pulp from getting involved into the resorptive site. And we will be able to intersections, we will be able to see that there will be multiple clastic cells in these areas, and there will be in the site of the portal of entry, you can see granulation tissue, but simultaneously below that we are able to see osteoid-like deposition also. So I've been talking about this PRRS. Is this definitely a protected? Yes. What does this PRRS contain? The PRRS contains the predentine, the dentine, and also bone-like tissue. And this is the layer between the resorptive site and the pulp. And why does this buffer or acts as a protection? Because the two reasons have been proposed. Because since it is away from the source of since it is close to the source of blood from the pulp, it will be having a lot of oxygen. That is, normal oxygen level will be there. And since hypoxia is not maintained there, the osteoclastic activity or the plastic activity does not happen. And the other reason they have quoted is this could be a hypomineralized structure. Therefore, the plastic cells cannot adhere to this. Doesn't mean that this is like an armor, but at some point of time, if the inflammation does not subside, the plastic cell will breach the PRRS and can affect the pulp also. So next is the repair stage. Once there is a reduction in the inflammation, the repair automatically takes over. For example, if you see this particular picture, here you have the point of entry, which is active with resorption with granulation tissue. But whereas this area 1 and area 3, you're able to see there is reparative cementum PDL cells form. So doesn't mean that one tooth will always have only active resorption. Even in the same tooth, just below the active site, when there is a reduction in the inflammation, we will be able to see bone-like tissue and bone-like tissue ingrowth into these areas where, and if it is adjacent to the PDL cells, we can also see reparative cementum and PDL cells forming in these areas. So the first part of it, I would like to kind of condense like what is the etiology and the pathogenesis of those, and trauma forms the predominant causes for the external cervical root resorption. PDL damage is very important because it removes the cementum layer. Cementum is again anti-resorptive in nature. So that protective layer, once it gets removed, the dentin is in the danger of getting into the resorptive area. And hypoxia also trigger ECR. Inflammation is the main culprit, that is the macrophages conversion from M1 to M2. That balance has to be maintained. So macrophages is the main culprit. So the treatment has to be aimed for reducing the inflammation, thus the polarization takes place and it can cause the reparative process. Calcium again decreases the osteopontin and also releases the lock and also reduces the activity of the proton pump. Therefore, it also reduces the plastic activity. Reparative process is the last step of the resorption, where bone-like tissue can form into the resorptive cavity, which is very important when we are going to analyze the treatment part. So that will help us determine whether we are going to treat the patient or monitor the patient. But I will be talking to you about the next couple of slides. Next is going to the clinical aspect of the resorption. This is not the cellular and the molecular level of the resorptive process. Now we are in clinical side. In 1999, this was proposed by MSA, which has been followed for a long time, probably till 2018. This was the only classification that we were following, and even the prognostic article that was given in 99 was followed for 30 years. So according to KSRIDSR, it is type 4 classes are there. Class 1 is very minimal in the cervical area of the tooth, which we can predominantly see like a pink tooth in the cervical region, and it involves the outer third of the dentine. But in class 2, it goes more deeper towards the pulp, and again it involves the cervical root of the tooth. In class 3, it undermines both the crown and up to the middle third of the tooth. And in class 4, which is more invasive, it goes around the pulp. It has the channels, resorptive channels runs deep into the tooth, even up to the apical third. But the problem with KSRIDSR's classification is one, it is two-dimensional. It is a radiographic assessment. See this picture, if you see, it is seen from the mesial or the distal side, but in a radiograph, we see the picture from a buccal or a lingual side. So this depth cannot be assessed in a radiograph. So KSRIDSR's classification's major problem was the depth could not be assessed. And when we have distortions while taking an X-ray, that can also cause the assessment problem. And most importantly, the reparative aspect of this particular defect was not assessed or been talked about in this classification. So next came the Patel's classification, where they have used the use of CBCT, and they have given the three things: height, circumferential spread, and proximity to the root canal. Based on that, whether it is the height, that is whether it's supracrustal, subcrustal, or apical third, or the middle third is the first category, under which whether this when it is circumferentially less than 90 degrees, or it is 90 to 80 degrees, or it is 80, 180 to 270, or really it is occupying the whole tooth. That is the next subcategory. And the third one is whether it is only involving the tendon, that is whether the BRRS is intact. And the last is the pulpal involvement. So based on this, we can have a mix and match of so many combinations. So we can have so many types of cervical root resorption. Roughly, we have 32 types of proposed classification by Patel. Again, Patel also does not talk about the reparative process that is involved in the this particular pathogenesis. So this reparative process plays an important role when we have to decide the treatment plan. So when we go to treatment planning, which will be the next part of my lecture, when we just type cervical root resorption, we see around 500, nearly 500 articles that just on one click in PubMed. And so under this, you see the management of cervical root resorption, you have more than 150 articles which deals on the management of the cervical root resorption. But unfortunately, there is no clear-cut guidelines or how to handle these particular type of resorptions. Yes, ESC has given a position statement. Patel and his group have given a position statement, but none of these articles will actually go through, will be following any of these guidelines. There is a lot of methods to treat this particular type of clinical situation. Recently, in 2022, the Athena's group has excellently developed a clinical approach strategy for both diagnosis, treatment planning, and also for following up. So they have given this it's not exactly come out of the guideline, but they have proposed this as a guideline which we can use it day in and day out for clinical practice for the treatment planning aspect. So what have they done? For diagnosis, they are asking us to consider the predisposing factor, the clinical examination, and the radiographic examination. And the predisposing factors, we have to see what is the age, which definitely makes a point. Even if you are able to hold the tooth for 5 to 7 years, yes, it is very important in developing age. If it's a 60-year or a 70 years old where a permanent option is possible here and we can extract it, yes, we can extract it. But if it's a 7-year or a 10-year-old where we need to retain the tooth, age has to be considered in the treatment part. Gender does not is not influencing much, and the tooth type has also to be considered. For example, if you are having an invasive circumferential spread of a canine, of a maxillary canine in a younger patient, whether we extract it or whether we are going to retain it is the question. So that depends on each clinical situation. But Athena's group has said that they have proposed that holding that canine is much important because it helps in the growth of the arch, and it's a very long root and it is a major player in the occlusion. So the particular type of tooth also plays an important part in treatment planning. Next is the type of factors, whether there is a cemental damage that's happening, whether there is any orthodontic force, there are any hypoxic conditions that's happening, or there is any plaque accumulation, or any other overhanging of the restoration that is causing chronic irritation. All these factors has to be considered during the when you diagnose a patient. So we have to consider all these things prior going on to the treatment planning. So under clinical examination, whether the patient is symptomatic, whether it has pain, discoloration, swelling, all those things has to be seen. Predominant of the patient who comes to us will not be complaining of pain in a resorptive tooth. It could be in a settled state, but still the patient may have a big periapical lesion. It could be non-vital. They will just say, I have a discolored tooth. It could be a non-vital tooth or it could be a pink spot. The patient may not have pain, but still the patient will have a periapical lesion. So all these things has to be considered. the most important clinical examination, as I told you, is the portal of entry. There, if you probe and you feel it is hard, that means it is having bone-like deposition is there and it is self-sealed. So in those conditions, whether there is a presence of bone-like tissue in the portal of entry and the size of the portal of entry, whether it is less than 0.5 is small and more than 0.5 mm is considered large. And then number of portal of entry has to be considered for every case. This is a very important step in treatment planning. Next is both IOPA and CBCT is become mandatory for assessment of the cervical root resorption. In the CBCT, we have to see the bone-like tissue in growth and whether it has smooth margin or irregular margin. Smooth margin indicates that there is some kind of plastic activity is also happening. Irregular margins may indicate it's an active resorption going on. This white line, I will show you the next two slides, is the PRRS, whether it is intact or it is breached. And also it helps in differentiating the internal root resorption to the external root resorption. These are a couple of cases from our own department where the patients just came to us saying their tooth is fractured or discolored. But once you see the IOPs, where I'll be showing you later, they had huge, massive cervical root resorptions, which we have managed. But here the patient has come to us with a sinus tract and we didn't even realize that he had a sinus tract. The patient had a deep pocket and they just came to us for a fractured incisor. And here they came for a fractured incisor and as a discoloration here, that this patient had a huge cervical resorption in this tooth from the palatal aspect and not from the buccal aspect. So these cases I'll be showing you later. And whether to use CBCT or not, these are all very young patients, like 10, 15 years old. Whether to use CBCT in these cases, yes, we have to use, we can use a minimum FOV with of 90 kb and resolution so that only the 4 or 5 teeth gets resolved. See, for example, in this case where there is, it looks like a mottled appearance. On the CBCT, we can see that there is a lot of resorptive tracts present. Though the portal of entry has a bone-like tissue, there is a huge resorptive channel that runs to the apical part of the tooth. So based on this, we can be able to get a better idea for the treatment planning. How to differentiate between an internal root resorption and an external root resorption is in the internal root resorption, we will see a ballooning of the canal. And in external root resorption, if you don't have the CBCT, you can take multiple angles and the resorption will move along and you will be able to see the canal line inside the resorptive cavity. This is how ways you will know whether it's an internal or an external root resorption. All these slides, I've been talking about nano-CT and all the histological sections of portal of entry. So will we be able to see a portal of entry from a CBCT? Yes. This is a clinical image from Mavrado's article where we are able to see some higher radiolucency here. But on a CBCT, the portal of entry is very evident. The resorptive cavity, though the portal of entry is very small, the resorptive cavity is so huge that you are able to see that it's going above the pulp chamber and below the pulp chamber, and the PRRS is still intact. All these factors cannot be located from an IOPA. Only through a CBCT, we will be able to decide the extent of resorptive defect and also how to handle these cases. So going on, how to handle the group, Mavrado's group has again given us the main factors that we have to consider is the pain or other clinical symptoms and the probing feasibility. What do they mean by probing feasibility? Is to the portal of entry, whether it is being able to probe or is it accessible, not accessible, or there is any bone-like tissue. From the radiograph or the 2D or the 3D, you will know the extent. What is the extent of the resorption and the presence of bone-like tissue in the portal of entry. So these four are the main characteristics which will help us decide the treatment plan. So here, if you see on probing, we are not able to find the portal of entry because it's completely obliterated with bone ingrowth. But however, in this case, it's a more or less a similar case, but it is active resorption is happening and there is no bone ingrowth, and there's only granulation tissue, and we will be able to see and we'll be able to probe into the cavity. Based on this, we can decide whether to extract the tooth, monitor the tooth, or we have to go for a direct treatment approach. Going on, monitoring. This Maverick group have given classic examples of where they have seen posterior teeth. In this first example, if you see, there is a posterior teeth bone ingrowth into the cervical area. It's a pretty large cervical resorption with bone ingrowth. After 2 years, they have repeated and followed up, and there is no radiographic changes. They have not just done anything, they just monitored it and they've left it. So it is still surviving. But similar case where you have a bone ingrowth when the patient reported, but after 3 years, there is definitely an increase in the resorption here. That means there is some kind of trigger factor still persisting. It could be trauma, it could be occlusion, biomechanics, or plaque accumulation here that can still trigger the radiolucence. That means it triggers the resorption and it's progressing. So this indicates that at this stage, we have to start interfering either to a treatment here or extraction, depending upon the case. And here, in this particular case, they have seen that when the patient reported, they had a lot of resorptive channels, but the point of entry is having the bone-like tissue. So still they chose to monitor it. After 7 years, they found that there is all the resorptive tract has been calcified and it has been nullified, and there is no resorptive channels and the tooth is still surviving. So treatment is not always the option. Monitoring can also be done in few select cases, and we have to know which case has to be monitored. So this is one case from our department which we got it published in JOE. This patient was our own student who came to us when he was 17 years old. His trauma was happened when he was 13 or 14 years old. He came to us for aesthetic purpose. He just wanted to replace his anteriors with more aesthetic aspiration. But on X-ray and sinus tract, we found that he had multiple inflammatory root resorptions. These are not cervical root resorptions. These are all inflammatory root resorptions, and it was humongous in nature. Incidentally, we also found I'm not going to talk about all the 4 teeth which had inflammatory root resorption. I'm only focusing on one which had extensive inflammatory root resorption on the buccal and the proximal side. But we were also surprised to find a external cervical root resorption from the palatal aspect and in the same CT, and we were able to see that there was bone ingrowth into this tissue, and that site we were not able to probe the site. We also took a 3D printing. Hannah and her husband John helped us out with this. They did this bone modeling was done. I'm not talking about 3D printing here because Hannah dealt it in detail. We did a 3D printing, and this was the model of the tooth. You've seen there's an extensive resorption inflammatory here, and it also had a palatal resorption. But this resorptive site was not seen in this case because there was bone-like tissue. So what we did surgery and we did treatment of the other teeth. We treated this tooth intracanal and extracanal with chitosan nanoparticles, which was the first to be done on patients in the endodontic literature. But we did not touch the palatal aspect. Whether the plastic activity stopped because we had treated another resorption, or the nanoparticles reached through the dentine, which was not clear, but we were able to arrest the plastic activity even of the ECR, and it did not progress even after 4 years. There was no treatment that was done for the palatal aspect. Only the buccal aspect and the periapical aspect was treated. The ECR was not treated, and we are having this patient under monitoring, and the patient, I think now we have 4 years of follow-up for this case. So this is where you monitor. That is when you have the portal there is no pain for the patient, and the portal of entry is sealed with a bone-like tissue and it is not accessible. We can wait and watch. That is the cases where you monitor. So when do you extract it? Initially, HSAs used classification based on class 3 and class 4. They were extracting all the teeth because it's a huge lesion, circumferential spread, and a large portal of entry, and there is no bone. But again, this is definitely a case for extraction, but of late, there is a shift in the material aspect, the treatment aspect, regenerative aspect has been coming into the field of endodontics. Again, we have to think about age, the periodontal damage, how much has happened, and whether we can relieve the hypoxia and what is the type. This is a canine teeth, so we will be wanting to remove this teeth. So those type of questions play, and the age of the patient is definitely we'll have to consider. So based on that, if If it's a frankly, we won't be able to restore the tooth, whether the teeth will be prone for vertical root fracture in the next couple of years, and the restoration is a big problem. The periodontal health will be compromised. These are the conditions where we go for a frank extraction. So where are we going to treat? So we talked about how to monitor, which cases we are going to monitor, which case we are going to extract. So which cases are we going to save? So in those cases, symptomatic patients comes to you with pain, or you can still be asymptomatic. Predominant of the patient comes to you asymptomatic, but they don't come to you with pain, but they may have a sinus tract, they may have a periapical lesion, or they may have a discoloration. So those kind of patients, and they don't have a bone-like tissue of the portal of entry. That is, we will be able to probe the portal of entry. In those cases, we have three approaches. One is internal, one is external, and one is a combination. What is the internal approach? When the patient comes to you with pain or any other symptoms, but he does have some kind of bone-like tissue in the portal of entry. In those cases, we don't touch the external surface. We go into the canal or we go into the cavity from the occlusal side. We can either remove the tissue of the esophageal tissue, we can do a vital pulp therapy, or if it's a non-vital tooth, we can do an endodontic treatment, and we can seal the resorption from inside of the tooth. I'll be showing few examples later. If you are able to probe the portal of exit, that is, there is a catch in the portal of entry, and that will lead to a lot of plaque accumulation. So we have to seal it from external. So again, external, we can only seal the defect, or we can do a vital pulp therapy if the pulp is getting exposed. That is, when the PRRS is defective, in those conditions, we can do a vital pulp therapy and seal it only external. We don't do a root canal, or an internal approach. So that is one kind of approach. The next is combined. There will be some cases where you have a perforating resorption from the external to the internal with a periapical lesion, a combination of all these things. In those cases, we do the endodontic treatment. We seal the cavity from inside and also from outside surgically. And in worst case scenario, we don't want to lose the tooth. We still want to hold the tooth for various other factors. We can also try intentional replantation. I'll be showing few cases in each of these categories, so we'll be able to understand better. So this is a case published by Mavrido, where they have seen a molar. In this, we are able to see that resorptive defect is completely having a radio-opaque nature, that is bone-like tissue. But when in the CT, they are able to see that there is bone-like tissue and also a radiolucent area here, and the patient was having pain. So what they did, they opened up the axis, and through the axis, they didn't open up from a flap. They just opened the axis and they're able to see the resorptive defect and the canals. After they use hypochlorite predominantly, they don't use trichloroacetic acid. So on using the trichloroacetic acid, they remove the tissue, and this is the PRRS sheet. That is the resistant sheet, which is they're able to see, and this is the portal of entry. So what they have done, they have sealed that with the bioceramic cement, and they also did the root canal treatment for this, since it's already necrotic. So this is an internal approach where they've done both the endo and the sealing of the resorption through the cavity and not from the outside. There is one more case report where there's a very young patient where he's come with the discoloration of the lateral incisor, where they have found it's pretty invasive and is too young to lose the tooth. And in this particular, though this looks invasive into the canal, but in this section, it's very clear that the PRRS is still intact. So they also modeled it. Due to the position, they did orthodontics to slightly bring it out for the axis. Once removing the removal of the tissues, they're able to see that the PRRS is intact and the pulp is white. So they just laid with glass ionomer and composite, and the tooth was kept under observation. And they also have around 3 to 4 years of follow-up, and the tooth is functional. So here they have not done any endodontic approach, but still it is an external approach where they have just done without a pulp capping procedure. In this particular case, it's a canine with a massive internal cervical root resorption. Since it's a canine, they wanted to save the tooth, and it is approaching the pulp. It's very close to the pulp. It's still the PRRS is there, but it's very close. It's a very big lesion, more than 90-degree circumferential spread. They've surgically opened it. It's an external approach, and they have seen that there's the pulp involvement. They have capped it, and they have closed it with glass ionomer. It's an external approach where they have not done the endodontic treatment. And again, they have around 10 years follow-up of this particular case. This is again a combined approach which we have done in our department of unfortunately, in our department, we have more of the cases with the combined approach because most of the patients that we encounter comes with huge periapical lesions and pain symptoms. So, and multiple tooth resorption and multiple surface resorptions also. So, most of our cases that we have documented will be in the combined approach. The patient came to us with multiple sinus tracts in 2-3 teeth, and we are focusing only on this teeth, which shows to have calcification and a small resorptive defect. We did take CT for this patient. It looks like a very small defect, but when we see the axial sections, we are able to see the bone ingrowth here. Though the bone ingrowth is seen, we were able to feel the cavity on probing, and the probing feasibility was present. We did 3D modeling for this case also, where we were able to see that there is some areas where the portal of entry is having bone-like deposition, and there are few areas that is above the crestal region where there is granulation tissue. So that is where we felt the catch of the resorptive cavity. The other 3 teeth underwent normal endodontic treatment with calcium hydroxide medicament. This tooth also was treated with calcium hydroxide medicament. Then it was obturated. Then we took this particular with the case with the mini surgical flap was taken. This is the resorptive defect where we were able to see that. Then that was debrided with trichloroacetic acid, and we filled it with biodentine and laid with glass ionomer cement suture. And we all have around 3 years follow-up for this particular case. The other case where this was one of the initial cases which I showed you, the patient was asymptomatic. He came to us saying he had discolored teeth, but once on an IOP, we were able in this tooth with calcification, and we were able to see some radiopacity in this particular tooth. And this made us think he may be having an PCR in this particular buccal side. So we took a CBCT for this particular case. Surprisingly, though there was a catch here, he had a external cervical resorption in the palatal side, which was going into the root. Also, he also had a dense invaginatus. We're able to see that he has a dense invaginatus in this tooth and this tooth. So the resorption was communicating into the dense invaginatus of this particular teeth, but the whole canal was calcified. So this is another section where we'll be able to appreciate how the resorption progresses and it communicates to the canal inside, but still the remaining part was more or less calcified. So for this particular teeth, we opened the axis, we gained the length, other teeth was normally obturated. But when we come to this tooth, whatever was seen as a mottled appearance, the moment we do cleaning and shaping, that gets removed and becomes a huge resorptive defect because it is not a full bone tissue there. It's a bone-like osteoid tissue which does not have the strength. So the moment you use hypochlorite and disinfect, that gets removed. So we did a periapical surgery for the other areas, and we also opened a palatal flap to seal the resorptive defect. And we've sealed it with biodentine both from inside and from we did an inside approach and also an outside approach, and we have around 3 years follow-up of this particular case. This is again an interesting case we had. When we got this case, initially we thought it was an internal resorption. So we took one more X-ray and we saw that this is moving along the X-ray. And again, CBCT confirmed that it is not an internal resorption. It is a resorption that's happening just below the CEJ in the cervical region. But we were also curious to see that there is quite an amount of preserved dentin between the resorptive site and also the canal. So we thought whether we can save it without any endodontic approach. But unfortunately, the tooth was non-vital and the patient, we had to go ahead with endodontic treatment. So though there is a PRRS, there could be some kind of leakage or communication from this to the site. Though there is a preventive barrier, the tooth was non-vital due to other reasons. So we had to do an endodontic and we did an endodontic approach, but also we did an external resorptive cavity filling with the biodentine, and we sealed it, and we have this case under 402. These are the couple of conventional way of treatment of with internal, external, or a combined approach. Nowadays, since there is a lot of bioceramic materials that is available in the market, and the utilization of the regenerative principles into the endodontics, there is a paradigm shift that is happening in the way we treat the resorption also. Here we see that there is a group by Asghari et al. They have used CE, and that is there is a calcium enriched mixture for treating a resorptive case, where this is a class 3 resorptive defect, where they have just done a pulpotomy here, and they have just vital pulp therapy is done with calcium enriched mixture, and they have holding the tooth without any endodontic treatment. Even in a class 4 molar with quite an invasive resorption with resorptive tubules, they have not done a complete root canal treatment. What they have done is they have debrided the resorptive defect, and they filled it with CEM, and they have just sealed the remaining vital pulp here and here. They have just done a vital pulp therapy, partial vital pulp therapy here, and the vital pulp resorptive defect is filled, and the partial vital pulp therapy here, and they hold the tooth into occlusion, and it's still functional. So they don't go in for an conventional endodontic therapy, because pulp vitality is very important, and it also has, due to the blood supply, it also offers some resistance to the progress of resorption. Therefore, they want to hold the vitality of the pulp intact. And this is a very massive case that has been a massive resorption that has been published, where the incisor has a huge resorptive defect. You see in this CT, it's circumferentially involving more than 180 degrees. And they have done the intentional replantation, where they've carefully extracted such a huge resorptive defect, where they have done our CT, our endodontic treatment. They have treated the site with removed all the plastic activity and resorptive cells. They have filled it with glass ionomer cement and closed with composite. They have reimplanted. They have a couple of years of follow-up with am I still audible? Am I still audible?
Yes, yes.
Yeah, okay, because since there was a call, I think the data got cut. Thank you. So they have follow-up of this intentional replantation case also for quite a long time. But unfortunately, these kind of teeth can fracture during extraction. And the kind of periodontal healing that can happen when you replant is a query. And because there is no opposing periodontium when you push this back into place. Another thing, as such, any replanted tooth is prone for resorption in the root side, such as the lateral borders can start resorbing. So these are the factors we have to consider prior taking up such cases. So at this point, I would just like to condense all the treatment approaches based on the parameters and give you one nutshell. Class 1 type of resorption is mostly very small, and an external approach or monitoring can be done based on the probing facility, whether the probe can probe the cavity or not. But when you go to the class 2, class 3, class 4 type of resorption, based on Mavrido, we have to consider the 4 parameters. That is the pain, clinically, the pain and other features, and whether we are able to probe the cavity. This is the clinical feature. And when you see the radiographic or the CBCT, whether there is bone-like tissue ingrowth inside, and the extension, whether it is class 2, class 3, or class 4, whether it is present or not. So based on this, how do they go ahead? So when there is no pain and you have a bone-like tissue, see, this too is inversely proportional. That is, when there is bone-like tissue inside the portal of entry, you won't be able to probe it. So this is inversely proportional. So when there is no pain and it is self-sealed in any of the cavity, we can still monitor for 3 months, 6 months, 1 year, 3 years, 7 years. To see whether it is progressing. We don't have to jump into a treatment. That is, the patient is asymptomatic and there is self-sealing activities. The tooth is under reparative process. Next is when there is pain. Yes, patient is symptomatic. Yes, periapical lesion or something else like that. But still he has a bone-like tissue in the portal of entry and we are not able to probe the entry. We can go for an internal approach. That is, do not touch the external root surface, go through the tooth and remove the remove the granulation tissue, see whether the PRR is intact or if it is exposing the pulp or not exposing the pulp. Based on that, you can go ahead with the vital pulp therapy, or you can also do a root canal if it is non-vital, but do not touch the external aspect when the bone-like tissue is completely intact or non-accessible to. Next is the pain is all, there is no pain. And there is a feasibility of probing. That is, there is a catch. Even the patient is symptomatic or asymptomatic, but the lesion is active. There is a granulation tissue, you are able to probe it. In that case, you have to have an external approach. That means the patient could have a vital pulp, but still have a resorption that's there outside and you're able to probe it. In those cases, maintain the vitality of the pulp, go for an external approach alone. Remove it and seal the defect from external. If the pulp gets exposed, in that case, you can do a vital pulp therapy or a pulp capping and close it. If the patient does not have any kind of pulp exposure, you can still wait and just do a resorptive defect filling. The last is when the patient is having pain with all possible combinations of periapical lesion, the defect is, doesn't have a bone-like tissue. This is the worst case scenario. In these cases, still the patient, we are not able to extract it. We have a combined approach. You have to fill it from inside, we have to fill it from outside, and depends on the present or absence of the BRRS, we decide what approach, whether we do a vital pulp therapy or we do a complete root canal, and we also seal it from outside. The last is whether we are going to extract or replant, depends on whether it's a very huge lesion, the tooth is prone for fracture, and we are not able to restore it in any ways. And even after restoration, the periodontal healing may be compromised, which can trigger future inflammation. In those cases, either we have to take a call whether we're going to extract it, or if it is possible to handle it gently with the replantation. We have to weigh the pros and cons here based on the case, and we go for either extraction or replantation. So the main 4 factors is whether there is a clinical pain and symptoms, whether we are able to probe the portal of entry, whether there is a bone-like tissue, and the depth of the lesion. This determines what treatment we are going to do and what is the prognosis. The last part is the prognosis of the treatment outcome. There are only 3 studies which massively deals with the treatment outcomes. Till 2018, we had only 1 study that was by Dentistry, where we had done 211 or 221 teeth, and they had given prognosis based only on that. Recently, 2 groups have given the prognosis or the true treatment outcome of these cases in a much mammoth way. The problem with these kind of cases is it's not as the incidence rate is not as high as any other endodontic lesion, and also the way clinically represent is so varied. We saw that it can represent itself in a way of 32 types. So the clinical representation is so varied. Therefore, we cannot standardize and do a randomized trial in such cases. And following up of such long cases is also very tedious to have some treatment outcome. But luckily, we have a couple of articles which can give us what is the outcome of these treatment in these cases. So the first, which is they have done up to 89 teeth for 4 years. They say 50% is the failure rate in the first 4 years itself. But the group by Mavrido, they have done a much more longer follow-up to 10 years. They have seen 542 teeth, but after at the end of 10 years, they have only having around 360 teeth that were evaluated. And in the end of 10 years, they had only 85 to 100 teeth that they were able to follow for 10 years. And up to 3 years, the prognosis is very good, up to 85%. Even up to 5 years, we have a success rate of any of the treatment approaches is up to 70%. But after that, it massively drops. So real long-term up to 10 years reduces up to 28.6%. With this, they accumulate that external approach may give us a very high success rate. And also monitoring was predominantly done for class 3, class 4 lesions. But nowadays, they say you can even monitor if there is a sealing is there in the portal of entry for all types of resorption. Posterior teeth failed more than an anterior teeth. The most common reason for failure was found to be vertical root fractures, obviously, because there is a lot of loss of root structure. Therefore, the weakness, the inherent weakness is there, and we fill it with restorative materials. We don't regenerate those areas. Therefore, the tooth strength is lost. So vertical root fracture and progression of the progression of the resorption is the next most common reason for it to fail. And all the articles, they have said class 1 and class 2 is having very good prognosis. This is one more article where they have seen only 14 samples of ECR with the surgical treatment, and they also found they have 100% survival rate. But this is in a very small sample size, and class 4, which is supposed to be the most invasive, was not involved, and they had only 3 years of follow-up in this. And this is an excellent article by Nikita's group, where they have assessed the role of CBCT in the treatment planning and also in the prognosis, where they found out they had documented 168 teeth, and IOP was taken in all those teeth, and CBCT was also taken in all those teeth. They have done segmentation, and they have calculated the amount of volume that is lost in a external cervical root resorption. They have assessed a couple of parameters. That is the portal of entry. Where does it happen? It predominantly happens in the lingual palatal side and then the buccal side. There is also a combination. They also found out whenever there is a proximal site where the portal of entry, the resorption start, it progresses mostly to the palatal side, not to the buccal side. So these will help us to determine the accessibility of the resorptive site for treatment. Again, they also found out more than approximately 70% of the teeth together cumulatively has more than 180 degrees spread. That is, it is very invasive. This shows that when the patient comes to us, only when it is really spread, that means it's predominantly asymptomatic patient does not know there is a resorption that's happening. So that is why the patient comes to us when it is massively spread to the full of the teeth. And obviously, since it's a cervical resorption, you find it more in the cervical third. Here, apical third means the resorptive channels are the spread of the resorptive channels to the apical third was up to 20% of the cases they have seen. The other thing they found out is up to 12% loss of the root dentine is there in the resorptive dip. That's an average value they have given. And these things was very interesting to find. This was the X-ray and the CBCT was analyzed by 3 examiners. And when they see the periapical leak with the when they assess the IOPA, they are able to say that, yeah, it can go for the treatment. You can surgically treat it much better with the periapical IOPA. But when you see the CBCT, the extent is much more. They are able to assess the extent of lesion much better. And the treatment plan, they differ to extract it when you use a CBCT as a tool. They also found the prognosis to be worse when you assess through a CBCT rather than an IOP. So whether you take up the treatment or not, and the prognosis is determined much better with the CBCT. So what are the materials that has been used for this particular type of clinical situation? When you see initially they were even using amalgam, then predominantly it was glass ionomer, then it was a sandwich technique, then they used a reverse sandwich technique of layering composite inside, then the glass ionomer outside. Nowadays biodentine MTA has also been extensively used, but there is no clear-cut guideline or any kind of evidence that says when you use tricalcium silicate, yes, the success rate is 70%. When you use glass ionomer, it is more. We don't have any current literature on this particular topic of what is the material that can successfully help in treating ACR. So as a simulation of the prognosis, I have just made all the 3 articles into one table, comparing HSA, Mavrito, and Irinex. So age is not mentioned here, but approximately it is 20 to 40 years. That's common. Gender does not make a difference. Females have a slightly more predilection to have resorption. Probably they're more of orthodontic treatment, not sure, but there is no statistical difference. Tooth still maxillary incisors is predominant, followed by the molars, which is more or less the same. And phalanges is more high in posteriors in particular article. And etiology, Hethersay had said it's trauma more common than ortho or coronal bleaching. That was in 1999. Currently, ortho is the predominant cause due to trauma, but surprisingly, this group has reported previous restoration is more common than causing resorption than trauma or ortho. The chemical they have used to remove the resorptive defect varies. Hethersay is used trichloroacetic acid. In this group is also used trichloroacetic acid. Mavrido's group is used hypochlorite because trichloroacetic acid is little caustic. It may cause tissue damage much more than a sodium hypochlorite. So they have preferred using hypochlorite. And again, glass enamel cement was mostly used in the study with the Hethersay, and here multiple variety of materials has been used, different treatment strategies has been used in these two articles. So the final thing of what is the prognosis of all this treatment, the different three articles, predominantly this group has documented a lot of cases. Overall 100% success rate over 4 years for class 1 and class 2 by Hethersay, which gradually decreases as the intensity of the resorption increases. But when we see Mavrido, since it's a long-term follow-up, we have only 50% even for a class 1 and a class 2. However, it's only 10%. I think this doesn't really improve much in any of the cases. But in the last group, they also had 100% because of short-term follow-up. They have very less number of teeth in this case. And they also have 100% follow-up. And in class 2, predominantly, they have more number of teeth here. But when you see these, Hethersay and Mavrido, more of class 3 is been reported. Here, they have reported more of class 2. And overall, with this article of Mavrido, we have around 70% as the prognosis or the treatment outcome over a period of 5 years is the average they have given for the treatment planning. So what is the future? So last slide. So what is the future? When we are going to see therapeutics of an external cervical resorption, one thing has to be borne in mind. The tissue interface we are seeing is not exclusively enamel or dentine or PDL. It is the multi-tissue interface. One side we have the cementum, dentine, we have the bone and the periodontal ligament. So it is a multi-tissue interface which needs to be regenerated or treated for. And there is a biomechanics that's continuously acting on this tooth surface. So all these parameters, along with there's a continuous ingress of microbes through the saliva, through the crevices, and the slight movement in the socket will always have a biomechanical force here. And therefore, there will be a persistent inflammation that can happen here. This has to be considered before we think about the future therapeutic options. So, according to Mavrido, if there is a bone-like tissue formation, we are monitored. But is bone-like tissue formation the ideal way of treating these kind of treatment is the question. Whether it really does it really strengthen the tooth from inside? Is that why the tooth fractures more? These questions are still to be answered when it comes to ECR. The nanotherapeutics and the regenerative options, yes, it does look very promising in the future. And this is the area where the research is happening right now. And this is the future for treating such complex tissue interface-based lesions. And I would like to thank my team, whole team, Avail sir and my whole department for always being there as a great support for me for all my endeavors. Thank you.
It was very well presented, Dr. Nandini. Now we are open to question and answer session. Over to Dr. Adra and Sudarshana.
Ma'am, can you hear me, ma'am?
Yeah.
Ma'am, the irrigation methods which we can use for cleaning the resorptive cavities.
Yeah, if it's an internal approach, we can still go ahead with hypochlorite. But make sure that we don't push everything into the resorptive defect. Here in our college, we use endovac. So what happens? It doesn't extrude into the beyond the apex nor into the resorptive defect. So we use endovac along with hypochlorite EDT, the normal irrigation regimen, and we also go ahead with the calcium hydroxide dressing for 3 to 4 weeks. Therefore, there is an osteoclastic arrest of the clastic. So that's what we want.
Okay, ma'am.
About the 3D printing in resorption management.
Yeah, 3D printing and resorption management, we don't make stents directly. What we used was to use it as a diagnostic purpose. It's all the cases that we have handled is not only a single tooth, small resorptive defect, it's multi-surface and extensive involving 3-4 teeth. In that case, when we use it for a diagnostic purpose, so we are able to assess it completely, what is the level of resorption in that particular patient. We are able to plan it much better. When it comes to resorption with bone defect, I don't think there's a need for a stent here because already massive destruction is there. When you open the flap, there's a big ball there. So it's basically what we used it is for the assessment of the treatment plan, how better we can handle it rather than using as a stent.
Any questions?
Okay.
Ma'am,
Yeah.
ma'am, any gene correlation between physiological and pathological resorption cavities, ma'am? Like
Yeah,
in
they
this.
have assessed. Yeah, they have assessed the MMP gene. MMP9 gene is being correlated for bone and tooth resorption. Yes, they have. And even the biomarker level of basically this is being done more on the orthodontic resorption. Orthodontic resorption is what is well studied with both proteomics and genomics rather than a trauma-based resorption. They have found MMP9 gene and cathepsin genes coding for cathepsin K, and also for biomarkers like TRAP have been studied, and they found a correlation between bone and these kinds of genes. Yes.
Thank you, ma'am.
We are happy now and delighted to give the certificate of appreciation to Dr. Hannah and Dr. Nandini.
Thank you, ma'am. Thank you, entire team. Thank you.
Thank you.
Kindly fill the post-test form and feedback form that has been sent to your mail. Kindly fill the form so as to receive your certificates. Now I request Dr. Bhupati to give the vote of thanks.
Thank you, ma'am. A very good noon to all. On behalf of Department of Conservative Dentistry, KSRIDSR,
It's
I'm
12:30.
glad to express the vote of thanks. I thank the management the principal, KSRIDSR, for giving the opportunity to organize the CDE program. I thank Dr. Hena and Dr. Nandini for accepting our invitation and for being here with us today in their busy schedule. The presentation topics were timely. The presented materials were on the new innovations in a way that everyone could understand. So we all enjoyed the time spent discussing today. And we're excited to have you again, ma'am. Thank you. Finally, I would like to thank all the participants for making the program a grand success. Thank you.
Thanks, Hannah. Thanks, Nandini.
Thank you, ma'am. Thank you.
Thank you. Thank you.
Dr. Hannah, thank you, Dr. Nandini.
Thank you, ma'am. Thank you.
Dr. Nandini, you rock the show. I'll talk to you. Superb.
Yeah. Right. Thank you.
Bye.